Hello, my name is Anthony Kronfli. I'm one of the general surgery residents, and I'll be giving a short lecture here about small bowel obstruction. A brief overview of the lecture today. I'll be going over the definition of small bowel obstruction, the different kinds of presentations, typical causes of the disease, as well as typical labs, imaging, and treatment options. So I'd like to start this lecture with a short clinical vignette that we'll circle back to. Sally Bridget Olson is a 45-year-old who is experiencing 2 days of nausea and vomiting accompanied by intermittent abdominal pain. She has a history of hypertension, hyperlipidemia, obstructive sleep apnea, and osteoarthritis, in addition to Crohn's disease. She's had an open cholecystectomy as well as shoulder surgery, and she's on the below medications, no relevant social history or family history, and on review of systems, she notes that she's been having less bowel movement. So the definition of small bowel obstruction is pretty self-explanatory. There's no need to overcomplicate it. The bowel is obstructed. 1 out of 5 surgical admissions for abdominal pain is typically due to a small bowel obstruction. And the old surgical adage, never let the sun rise or set on a small bowel obstruction, was said typically because these can evolve into a pretty serious condition, which we'll get into later. Alternatively, they can actually be self-resolving and unfortunately occasionally need an urgent operative intervention. So the clinical presentation for an early small bowel obstruction, as opposed to late, is usually nausea, vomiting, with new onset constipation, as well as colicky, intermittent abdominal pain and distension. A late small bowel obstruction is typically characterized by fever, obstipation, which is 0 bowel movements, and no flatus, as well as constant abdominal pain. The pain is secondary to distension of the bowel wall. Peristalsis typically continues in a small bowel obstruction proximal to the point of blockage, and this peristalsis, because it is intermittent, makes the pain intermittent. If you think about it from a physics perspective, the wall tension of a cylinder, aka the bowel, is proportional to the pressure inside the lumen of the bowel times the radius. So as pressure builds proximal to the site of obstruction, the tension on the bowel wall increases, which makes it more difficult for the bowel wall to receive perfusion, therefore placing it at risk of ischemia, which we'll get into here later. So to summarize, small bowel obstructions are characterized by nausea, vomiting, colic, again intermittent abdominal pain, constipation versus more serious obstipation, as well as abdominal distension. These findings are by no means specific for small bowel obstruction, however. So I've broken down the causes of small bowel obstruction into 5 broad categories. The most common cause is adhesions. Second most common is hernias. More rare causes can include inflammatory and infectious etiologies, such as Crohn's disease or abscesses. And even rarer than that can include gallstone ileus, traumatic mural hematomas, intussusception, or foreign bodies. So again, number 1 cause of small bowel obstructions, typically secondary to intra-abdominal adhesions. These typically occur after any abdominal or pelvic surgery, although they can sometimes form without any prior surgical intervention, although this is a rare cause. Laparoscopic surgeries are thought to cause less adhesions, however, this has never been proven. There is unfortunately no way to see these adhesions on imaging, and sometimes, if the surgeon suspects this to be the cause of small bowel obstruction, an exploratory laparotomy or diagnostic laparoscopy is the only way to be sure. Hernias are the second most common cause of small bowel obstruction. Physical exam is important in order to identify the hernia defect and evaluate whether the hernia is incarcerated and needs to be reduced in the operating room. Inflammatory etiologies can also produce small bowel obstruction, typically over the long term. Strictures can be caused by inflammatory bowel disease. In terms of infectious etiologies, mesenteric adenitis, often mistaken for appendicitis in children, can also temporarily cause a small bowel obstruction and typically resolves without any intervention. Radiation enteritis can occur, as well as ectopic endometriosis on the small bowel. In terms of inflammatory bowel disease strictures, these often require multiple days of steroid therapy in order to successfully treat. However, this is not a guaranteed fix, and sometimes these patients must proceed to the OR for evaluation and sometimes resection of the stricture. And as I mentioned, adenitis typically resolves. Different forms of malignancy can also eventually lead to an obstruction. Ileocecal mass, lymphoma, and different types of metastases, including colorectal, ovarian, gastric, pancreatic, or melanoma cancers, can cause this, and even more rarely, primary small bowel tumors, such as carcinoid, GISTs, or adenocarcinoma, can produce obstructions either intraluminarly or from compression on the outside of the small bowel. A brief note on the rarest causes of small bowel obstruction: intramural hematoma, which can occur after trauma; foreign body, such as seeds, toys, or even parasites; intussusception, again mostly in children but can occasionally occur in adults; and certain congenital causes, such as malrotation, can all cause obstruction. A quick note on gallstone ileus, as this tends to pop up in exams. This is caused by a fistula between the gallbladder and the small bowel itself. So any stones that formed in the gallbladder, instead of traveling down the cystic duct, will fall right into the small bowel and sometimes can travel distally and literally block the entire small bowel lumen. The number one location of the fistula is in the duodenum. So this usually will become lodged proximal to the ileocecal valve, again the end of small intestine, if it's larger than 3 centimeters in size. Otherwise, it's usually able to pass through the ileocecal valve. The treatment for this is going to the OR, making a small enterotomy, and removing the stone on direct vision, and then closing the hole that you made. A quick word about ileus, which is completely different from small bowel obstruction. An ileus is when the small bowel does not peristalse at all, and is typically seen either postoperatively after a surgical manipulation of the intestine or secondary to gross electrolyte imbalance, such as hypokalemia, hypophosphatemia, or hypomagnesemia. When we get consulted on this as surgical residents on the wards, we typically recommend that these other managing services hold narcotics as well as calcium channel blockers and correct any electrolyte imbalances in order to facilitate resolution of the ileus. Typically on CT imaging, you will not see a focal transition point, which is the key thing that will help you differentiate it between that and a small bowel obstruction. Right. So now that we've gone over the potential causes of small bowel obstruction, this is a good order in order to ask the patient to delineate potential causes of their obstruction. A history of abdominal surgery, which can potentially clue you in to adhesions being the cause. Any hernias on physical exam, which can potentially cause a blockage. History of malignancy. Anything in their history of present illness consistent with signs of infection, which may clue you into mesenteric adenitis. Any recent abdominal trauma, which could have potentially caused an intramural hematoma. Or any history of Crohn's or UC, which may be the cause of any strictures that were undiagnosed. And here's a brief overview again of all the causes that we just discussed. So what will blood work typically show with small bowel obstruction? Depending on the severity and how long the patient has been obstructed, you can see a leukocytosis as well as hypokalemia, and if the patient has been vomiting due to their obstruction, hypochloremic metabolic alkalosis, which, as you guys probably know, is often associated with pyloric stenosis in kids on your exams. Sometimes you can also see lactic acidosis, which is a byproduct of anaerobic metabolism, seen in glycolysis. It's important to note, however, that with closed-loop small bowel obstructions, you might not see a lactic acidosis. Right? This is something that some of the attendings might try to quiz you on the wards. Because there's no venous return with closed-loop small bowel obstruction, all of the lactate that's building up in this ischemic bowel is not able to declare itself, if you will, in the systemic circulation. So when you get a lactate lab level, it'll appear normal when in fact it is not. Just be careful of that.
Sure.
So after initial blood work, you can typically start with an abdominal x-ray. Best way to identify free air is to get an upright. You will not be able to see this on a flat film. However, x-rays are only 67 to 83% accurate in terms of diagnosing a small bowel obstruction. On x-ray, you typically look for any bowel distended greater than 3 centimeters, look for decompressed distal loops, paucity of air in the colon, which would sort of imply more proximal obstruction in the small bowel, air fluid levels, a gasless abdomen, which simply means that the bowel that's obstructed is filled with fluid, so obviously you won't see any of the air on the abdominal film. And again, I can't stress it enough, look for free air, because that is typically an indication to go quickly to the operating room. After a quick abdominal x-ray, you can move on to a CT scan, which will give you more information and likely be able to help you identify the specific cause of the small bowel obstruction. It's important to give IV contrast because any bowel that is ischemic and not receiving good blood flow will not light up with the contrast. And again, the big take-home point is to find the transition point. If you find that, you'll typically be able to examine that area and hopefully figure out what the cause of the obstruction is. The really scary things you need to look for on CT imaging include pneumatosis, which you can see in this image here on the right, as well as, again, like I mentioned, decreased enhancement of bowel, any mesenteric edema, and portal venous gas. This image on the bottom right here is a extreme example of portal venous gas. Obviously, there should not be any air within the liver. One final imaging modality is what we refer to as a small bowel follow-through. We give patients water-soluble contrast, either orally or through an NG tube, and it can help us better localize where obstructions are if we cannot see them on the CT scan. Typically, the rule we like to use is if contrast is able to make it to the colon within 24 hours, patients are more likely to resolve the obstruction without any surgical intervention. This is both diagnostic and therapeutic, as the contrast given is hyperosmotic, can help draw edema out of the bowel wall and help to restore normal peristalsis to the small bowel. So the final thing we need to discuss is treatment of small bowel obstruction. Typically, the conservative management entails nasogastric decompression to allow the proximal bowel to decompress, which can encourage resumption of peristalsis. And we also leave patients NPO until they begin passing gas, again indicated by that figure at the bottom right of the slide. We also fluid resuscitate them and replete their electrolytes to facilitate peristalsis again. It's very important for patients who have some abdominal tenderness to perform serial abdominal exams in order to determine whether the patient's obstruction is getting worse and potentially whether their bowel is becoming ischemic. You can also trend labs, which we already discussed which to get, as well as electrolytes. You can trend the amount of fluid coming out of the nasogastric tube. This should theoretically be going down after a few days. And if the output is staying the same, then it may be time to consider surgical exploration after a few days. Again, the big thing is whether or not the patients finally pass gas. So some of the indications for surgical exploration include hemodynamic instability or peritonitis on exam, high nasogastric output after 3 days of watchful waiting. Some texts define this as over 500 cc's out of the nasogastric tube within 24 hours. Persistent pain after 4 days. Again, if conservative treatment is working, pain should be improving day after day. And if repeat imaging shows the same or worsening of the obstruction, these are all indications to proceed to the OR. Some exceptions, again, where patients is warranted, include some strictures. I had mentioned earlier that steroids sometimes take weeks to reduce the inflammation enough to allow resolution of the stricture. The same is true with intramural hematoma, in that the hematoma takes weeks for the body to resorb and therefore resolve the obstruction. Unfortunately, sometimes those patients need nutritional support, as they won't be having anything by mouth for a long period of time, and that's when total parenteral nutrition comes into play. Some patients require immediate operative exploration and should not be trialed on conservative management. Examples of this can include a closed-loop obstruction. There's a pretty good figure there in the middle of the slide of that, as well as irreducible hernias and failure to progress, as we already mentioned, with conservative management. So typically, when the exploratory laparotomy is chosen, lysis of adhesions can resolve the obstruction if that's the cause. You can reduce the hernia and potentially perform a hernia repair if the patient hasn't perforated any bowel. You can perform an oncologic resection, keeping in mind that margins are important. You don't want to just take the small bowel, you need to also take the lymph nodes, just like that figure in the bottom right there, so you don't leave cancer behind. And you also need to resect any frankly perforated bowel. Sometimes we forget to do this, but it's always important to remember to place a nasogastric tube at the end of the case, as these patients will likely take a long time to have a resumption of small bowel function. In the setting of malignant obstruction, sometimes we can find what you can see here in the upper right corner, which is carcinomatosis, aka diffuse metastases. In this case, you can often do more harm than good if you attempt to resect all of the small bowel that's involved, which can sometimes be a lot, if not all of it. In this setting, you can offer patients a percutaneous gastrostomy tube, which allows decompression of the GI tract without a nasogastric tube. So to summarize the treatment options, you can pursue NG tube decompression first, as well as fluid resuscitation. Continue to monitor the patient for return of bowel function and for improvement in abdominal pain, if present. Be ready to proceed to the operating room if the patients don't improve within a few days, or be ready to proceed immediately if patients have an irreducible hernia or peritonitis. And in the setting of carcinomatosis and malignant obstruction that cannot be resected, you can consider placing a percutaneous gastrostomy tube to approximately decompress the patient for a long period of time without a nasogastric tube. All right, so let's circle back to the original vignette. Looking through this clinical presentation, some concerning findings you should be aware of included the nausea and vomiting. So consider the electrolyte derangements we previously discussed, as well as the intermittent abdominal pain. This is less concerning if the patient had constant abdominal pain. There would be a higher likelihood of a surgical emergency. The past medical history is notable for Crohn's disease, which, as we discussed, could be a clue that stricture might be one of the etiologies of this patient's obstruction. However, they've also had an open abdominal surgery, so adhesions can be at the top of your differential. Their azathioprine, which is likely for their Crohn's disease, might be an indication of the severity of the Crohn's. Nothing in the social history that would clue you into anything in particular, and the amount of bowel movements they're having at this point is less concerning than compared to true obstipation, where they haven't been having any bowel movements. Seen here are the patient's vital signs, as well as their abdominal exam and electrolyte abnormalities. Take a moment to read those. So the main findings here that might indicate the need for more urgent intervention include tachycardia and diffuse abdominal tenderness, even though it's mild, as well as a lactic acidosis. Lactate, again, over 2 is abnormal. So that accompanied by their leukocytosis and their moderate hypokalemia should make you concerned that they might need intervention. However, this ultimately might depend more on the imaging, so let's take a look. All right, so here's an example of a KUB. Let's say it's for this patient. Fortunately, there's no signs of free air, like I showed you in the other example. The small bowel is moderately dilated, not too bad, and there are air fluid levels. You can best appreciate that on the left side of the image. No gas or feces is seen in the large bowel. So again, remember, if the large bowel is decompressed, that can be a sign of a proximal obstruction. So here's an example of a abdominal CT scan. Again, IV contrast is important because that will tell us if any of this bowel is malperfused secondary to the obstruction. We're getting down here into the pelvis, and we're going to scroll up here in a second, and I will point out to you with the cursor what the obstruction is in this patient. So there in the right lower quadrant, you can see that very thickened segment of small bowel, which if we trace back, there is the transition point. So there's that large bit of small bowel decompressing into that stricture. I obtained that CT scan from Radiopedia. I actually recommend you guys check out the small bowel obstruction page. There's plenty of really good examples of CT scans of showing different causes of obstruction. So let's change the vignette just a little bit. So let's say you get these labs back and you find these findings on physical exam. So the major change here, the patient's still tachycardic, but now they have an incarcerated ventral hernia that you cannot reduce. Their white count is a bit higher and their lactic acid is much higher. So do you think we should go ahead and wait for a CT scan, or should we just proceed immediately to the OR? You should probably go straight to the OR. Any delay, for example, imaging, could potentially allow more small bowel to die, and you might have to resect even more, which can worsen patient outcomes. All right, so one more alteration to the original clinical scenario. With this patient who presents with overall normal vital signs, albeit a little hypertensive, and a more or less benign abdominal exam, normal lactic acid, and a slight white count. This is the patient, again, assuming no insidious findings on CT or X-ray, you could potentially pursue conservative management with nasogastric tube decompression, fluid resuscitation, electrolyte correction, and serial abdominal exams, and hopefully this patient will have return of bowel function without surgery. And that is an overview of small bowel obstruction, all of the causes, typical treatment options, and a little bit of some review of the imaging. Hope you guys learned something. Thanks for listening.